Okay, and you got any questions, you can free to ask him. As usual, what we have done now is I've given them a link for them to actually put in the questions, and the questions I'll send after the session lah, if we not able to answer during the session. So without further delay, I'd like to welcome Dr. Paran to present his lecture on professional health.
Thank you, Dr. Naveen, for the kind introduction. So, good afternoon, everyone. I hope everyone is refreshed after the break and your lunch. Right? It's a bit tough in the afternoon. Can be a bit sleepy post-prandial, huh? Right? So, but I'll keep it to time, and I hope to get attention, everybody. Yeah. So, without further ado, I will proceed with my talk. So, my talk is on professional health. Yeah. Which I Oh, I can see Selvam, huh? You're there. Huh? Are you still in Sabah? Or is it Sarawak? Is it? Okay. Hope they are online. Okay. Is it visible?
Yes, you can see your slides.
Okay. Thank you. Just one moment. Mm, Right. So, my first question to everyone will be, maybe you're wondering, what is professional health? Right? Would anyone here like to mention what is it? You can put in the chat box if you want. Actually, I can see unless I exit the. Or okay, there's a chat box there. Okay. Okay, some of you mentioned is physical and mental health. Okay, yeah, that's true also. Any other opinion? Was professional health? Okay, I'll not keep you all guessing. I will go on. So you can see pictures of doctors here, right? Right. So what is professional health in this context? I'm talking about doctors' health. Okay. So this is a practice skills workshop. So we're going to talk about doctors' health. Yeah, that's the purpose of this topic here. And we minimize my window. So I'm sure all of you have heard of the challenges in the medical fraternity. Almost daily, there are news and articles about doctors. This was some time back in year 2022, which is not that long ago. It was about 3 years ago only, yeah. But we still have these issues. So there's a shortage of doctors roaming in HKL then. So these Hartal doctors were talking about it. I think there's still shortage of doctors in HKL and in many hospitals and in many places as well. So the issue is still going on. It's not actually been resolved. And also about contract doctors, some of them got disappointed. So they are considering even migrating, to other countries for greener pastures to get better opportunities. Right? And this issue is still going on. A lot of doctors are actually also leaving to other places. Then there is issues of what do you call bullying among doctors, the seniors, the juniors. They have some issues, specialists and medical officers or colleagues, and so on. So there's this issue as well. So it's been discussed in various platforms. And then placement for housemanship. I think more than 5 years ago, it was a big issue because at that time there were a lot of doctors and not enough housemen. But I think the situation has reversed completely now. Nowadays, we're having less housemen, not enough housemen, right? And so this situation, I think, resolved on its own, no? Because people burn out. And then at some time back, there is also the issue of critical service allowances, which was cut because the PSD or JPA says it's not meeting the criteria. But I think this issue is resolved since then. And then we had COVID as well. So that was about 4 years ago. A lot of doctors face a lot of challenges. We were the frontliners, and those of us in primary care, you know what a difficult time it was. A lot of us were frontliners. Yeah, we were the ones managing these patients when they come to the clinics or the COVID assessment centers and so on. And a lot of burnout was present during that time. Yeah, and then there's also a call to have extended hours, overtime, and all that to cater for the community and patients who need medical care after office hours. Mm. And so, looking at all this, so naturally we'll have some questions, right? So, based on all these challenges and difficulties in our career and workplace, so do we fall ill? Do doctors fall ill? Obviously, we do, isn't it? Yeah, we're as human as the rest. But do we care for our doctors? That's the other issue. Yeah, do we care for doctors, especially those who fall sick. Yeah, and then okay, we care. How are we caring for these doctors? That's the other issue which I will discuss. Is there any preventive medicine plan for our doctors, colleagues? Do we have plans for them? Yeah. How to prevent them from falling sick or regular checkups and so on. And then again, if we fall sick, how do we treat ourselves? Do we treat do we practice self treatment or do you have other colleagues to turn to? Do you have another doctor to turn to when you're sick? So these are the issues that I'm going to discuss. And I'm going to talk and discuss it. So let's look at some of the definition of doctor's health. This is the Australian definition, which I think we will go into. Of course, this program is a GCFM, no? And the collaboration with the Australian fellow FRACGP. So we look at their definition. So they say that physical physician impairment is defined as any physical, mental, or behavioral disorder that interferes with the ability to engage safely in professional activities. In other words, we may fall sick, but not necessarily we are impaired. Yeah, we can still continue practicing. Yeah? But the moment we are impaired, that means it interferes with our ability to practice, to engage safely in our professional duties. And it's not just a state of complete, ideal physical, mental, social well being. Yeah? But it's not merely the absence of disease and infirmity. So we want to be ideally completely well in many ways, physically, mentally, and socially. And so, doctor's health is basically the understanding and practice of self health behaviors among doctors. Yeah? And this is a well known maxim. Yeah? Healthy doctors will lead to healthy patients, right? Yeah. Good lecturers and teachers, you'll have good students. Yeah. And similarly, healthy doctors, you have healthy patients. If the doctor is sick, how is he going to care well for his patients? Obviously, we can't, isn't it? So, in this scenario, we have doctors who made the ultimate, what do you call, sacrifice. One doctor was killed traveling and crashed in the highway. This was in 2014. Then in 2015, another doctor died on the way home after on call. So some say maybe he fell asleep due to fatigue because on call and all that. And he doesn't spare anyone, even our former health deputy DG, Dato' Jay Indran. He had also passed away at relatively young age of 64. Yeah. The news was that he had some cardiovascular condition. That's when he collapsed and he died. So he doesn't spare us, yeah, despite us being doctors and so on. In fact, there's some studies say that even doctors, die early There's one study from the Indian Medical Association. So they live shorter than others people, and many of them also collapse after surgery, after- due to cardiac arrest, and so on. And I'm not sure if you all know this doctor. He's a Chinese physician from China, and this happened during COVID-19. He was among the first few who highlighted and announced the what do you call the new disease. COVID was appearing then. They were not sure what exactly it was, but he was among the first few who gave out the alert that this new disease there and that many patients are succumbing to this disease. If I'm not mistaken, he's an ENT doctor, but he himself finally succumbed to this COVID-19. He passed away. So many doctors had also passed away during the COVID-19 pandemic. So back to our doctor's health and well-being. So this is by Amanda Howe, a very famous professor of primary care. So she mentions that being a doctor poses particular risk to one's health, as well as having aspects that enhance well-being. So it can be bi-directional. Okay, we have risks to our health because we're dealing with sick patients, yeah, infectious diseases, mental health conditions, and so on. And that is why some doctors even get additional leave in certain disciplines, such as respiratory clinics. They have an additional 2 weeks leave in a year. Those who deal with mental health patients, always dealing with depressed or very highly mentally unwell patients, it can impact us in some ways. And also those in the radiology unit exposed to radiation. So they have particular risks. And we also, even in the primary care, we are exposed to this risk, though maybe not in a substantial or prolonged time as in some disciplines, but we do come across such patients as well, as well as having aspects that enhance our well-being. So how does it enhance our well-being? Well, it can make us more empathic to patients. We seeing sick people, we tend to appreciate life better, ourselves better. We have more understanding, we are more caring than perhaps those in other disciplines because we come in contact daily, almost daily with patients who are unwell, for needing care, and so on. So that's also a very noble profession, being a medical doctor. So as I mentioned, the direct exposure to potentially harmful conditions, environmental risks, and also considerable risk of stress-related psychological morbidity. So there can be a lot of stress as well, yeah, and self-harm due to addiction. So sometimes some of these doctors they turn to substance abuse, and because to release the stress, hopefully not many, but it's not zero. Some of them may start smoking or even take drugs or alcohol and so on, yeah, to treat their, I mean, to self-treat their own stress, can lead on to addictions. And we also know that doctors tend to underuse our health services because we are so much dealing with patients. Okay, we are needed to take care of other people, so we tend to underuse the health services ourselves, and thus the empathy that we extend to others doesn't always come with the same care that we give ourselves. Okay? And this was mentioned in year 2013, the BMJ, and I think it still rings true to this day. Am I correct? Yeah. We do a lot for others, but are we having the same standards of care that we give to our patients? And at the same time, we must remember that doctors are also an important resource for society, and a lot of public resources are put into training. Okay, I'm sure a lot of you here are the cream of your crop. It's not easy to get into medical field. Okay, you need high academic achievements, right? And there's also a cost to it. Okay, for those who are, those on scholarship and paid for in the public universities is fine. But otherwise, it's also a lot of cost, yeah, to train a doctor. Yeah. In the UK alone, it's about £250,000. Okay. In Malaysia, recently they even increased the fees. I read that in University Malaya it's something like 250,000 to 300,000. Now they've increased it to 500,000. Yeah, that's the cost of just undergraduate. We are not talking about postgraduate even. Okay, even postgraduate training, further expenditure there. So in the UK alone, the medical students have average debts of about £25,000 by the time they graduate. So I'm not sure what the cost in Malaysia is. Okay, there are many estimates, but definitely hundreds of thousands cost runs into it. So it's not cheap. It's not easy to become a doctor, but at the same time, they're also a very important resource for our society. Yeah. We want the best to serve the public, yeah, because we are dealing with people's lives. So we want the best to be there. And if these doctors fall sick, especially if it's an avoidable disease, okay, it's such a waste, isn't it? It's a waste to the health service, a loss to our patients, and we also stress our colleagues and we disrupt our own careers. Okay. Frequently I get some of my colleagues, not frequently, occasionally I get some colleagues fall sick. We can cover, right? But it does lead to stress on colleagues. There are a shortage of doctors and also patients, right? They tend to miss their appointment with these doctors, so somebody has to cover for them. And sometimes you may have to disrupt your own career if you're planning postgraduate studies and so on. No? And sometimes there are many personal tragedies. Tragedies arise as well because they are not detected early. And they may fall sick, okay, and can be very serious, okay, can be admitted or even cause death if it's not detected early. At the same time, we are sick and we are treating patients, we can also pose a direct risk, isn't it, to these patients. Okay, we can't be coughing and having infectious disease and treat patients. We might, infect these patients. And at times you're mentally unwell, fatigued, tired physically, mentally, right? We may give suboptimal care, right? So we may release the stress onto patients, right? Leading to suboptimal care or satisfaction even among patients. Right? Supposing you're on call, you can't sleep, right? So next day, how are you going to perform? Can't be your best, isn't it? And as I mentioned, we are risks at the same things as our patients. We are not immune to diseases. We're not immune to chronic conditions. We're not immune to diabetes or hypertension. We also can be victims of aggression. Okay, aggression by whom? By our patients, colleagues, staff, okay, and so on. When at home, okay, domestic violence, we are also at risk. But we are particularly at risk because we are in the frontline services. Okay, we are among the first, what do you call, first care for patients. So we can become targets for attack. And right, so I already mentioned infectious disease. And some doctors also seem to neglect their own healthcare. And we know that there are many studies showing that we underuse of health services. We don't take up screening or immunization as much as we should. Okay. But nowadays in the Ministry of Health, it's usually made compulsory to have our vaccinations and so on. And for those who are above age 40, we are supposed to do screening annually. Okay. What about other risks for doctors? Because of the nature of work itself, very high demand, low control. High demand for doctor services. In other words, we got a lot of patients in our patient department, example, and we have low control. We can't actually block the clinic or close the clinic. Right? Many times you have to open it. And at the same time, there's uncertainty, yeah, when we fall sick and so on due to high personal responsibility. Okay. And then trauma from witnessing suffering. Okay. Sometimes we come across patients who are suffering and that trauma actually transfers on to us, right? So if you see a very depressed patient or physically suffering, okay, we can take on their suffering as well, and we can lead to a negative outcome. Though many work environments do adopt positive and protective cultures, but still many of us report excessive workload, especially now with a lot of doctors and medical staff, including nurses, okay, leaving to the private sector or even overseas, okay, because of various dissatisfaction and so on, or poor rewards, okay, or negativity in the relationships between colleagues or superiors or even juniors, and sometimes lack of supplies or infrastructure, right? In some cases, institutional failure. I wouldn't want to go into too detail into this part, but I'm sure there's always a lot of news in the media about these. So, working environment can exacerbate risk and also factors such as choice of specialty. Okay, certain specialties maybe uh, has more demands on the doctor. For example, those who are a lot of on calls and so on. Those who are dealing with very sick or terminal patients, such as oncology, okay, psychiatry, for example. Primary care is a mix. Okay, we do see a lot of such patients as well, and also the stage of career. So, what stage of career when you are doing, for example, postgraduate? Okay, there's extra demand. Okay, you need to spend time studying, doing your assignments, okay, your coursework, your exams, and so on. So there's also more demand on the individual. Gender as well may have an issue as well because especially women sometimes they have issues with childbirth, okay, childcare, okay, and housework and so on. Okay, there may be other issues as well. Okay, so this study shows that study from South Africa. Okay, psychological problems are more common early on in our career, right? Because probably we're still learning the ropes. Okay, so more doctors in the housemanship time or early medical officer days. Okay, they're more psychological problems. Okay, they're just learning to cope. Okay, the senior ones, by the time hopefully they've already learned how to cope with these psychological issues. And then there's also issues of burnout. Okay, I've seen many housemen actually leaving, resigning. Okay, whether dissatisfaction or burnout, or depression as well. Okay, and so on. And so we know that, uh, right, in this study from UK shows there's psychological problems are more common in doctors. And 27% of UK doctors show significant stress, and 7% of lifetime prevalence of substance misuse. Okay. And the suicide rate is slightly higher than the general population and significantly higher than other professions such as lawyers. Right. Okay. So this in US, so they say about 400 doctors actually commit suicide annually. That's equivalent of an entire medical school annually. Yeah? Okay, this in US. I'm not sure about the figure in Malaysia. We hope no doctors actually commit suicide. So summing it up, so a lot of experts in the field say doctors are high risk for burnout, substance abuse, psychological disorders, all as a result of work-related stress. And some of it actually deny it. Right? That means they do not really voice it out, such as stressful incidents during workplace. Okay, we in my setting, I usually try to do a debriefing. Okay, if it happens, violence and trauma in the workplace. Okay, if there's some physical violence, or some injury, workplace issues such as bullying or harassment can be an issue as well. Workload concerns, too many patients, too much workload, too long hours, right? And patients' problems. Okay, come we take on patients' problems. That's also an issue. Okay, some doctors are very empathic, but sometimes they tend to take on their patients' problems. So means they internalize these patients' issues. And then you need to plan your professional life, okay, your career plans, your own personal issues, your own well-being, okay, and how you deal with stress and so on. So, and again, I mentioned they're susceptible to long hours, and there's also a culture of coping. Some doctors think they must be superheroes. They should be able to cope, regardless of workload, exhaustion, and illness. So they even come to work when they are sick. Right? And also depends on system of healthcare delivery. Sometimes it's unstructured. Okay, if it's not well structured in your workplace, okay, you don't have placement accordingly or enough doctors, accordingly to where there are patients. Okay, it may be an issue, and there is also the issue of remuneration, yeah, or your pay. So some doctors feel it may not be justifiable, okay, the amount of salary or the compensation in accordance with the current cost of living, and some of them may even have education loans. Okay, also, pay off. So these are some quotes from doctors themselves. So the close relationship GPs have with patients are a source of ongoing stress. You may be very close to your patients, but that can be also a source of ongoing stress because patients may make demands onto you, and then colleagues emotionally unable to support me. This one doctor was saying, so they feel unsupported, right, by their very own colleagues. This is very sad, isn't it? Yeah. And of course, some of them mentioned some of their colleagues think that they are superhuman. Okay, they need to come to work every day, even they're sick, right? They need to cover for other colleagues and so on. This is a survey in the Irish College of GP many years ago, but I think it is still rings true even today. So this survey was done in 2001, this Irish College of GPs. Most GPs do not use the services of GPs at all. In other words, we primary care doctors are not even seeing our own colleagues. Okay? Either we ignore our illness, carry on working, or admit to diagnosing, treating, managing your own illness. That's a bit ridiculous, right? Yeah. Are you going to treat yourself, manage your own illness? Okay, that's a bit challenging, isn't it? Yeah. So I'm sure a lot of you do this corridor consultation, okay, or self-prescribing. Okay, you consult your colleagues in the corridor. You don't actually check in and register and open a file, but you just discuss with your colleagues. Hey, I think I got this. I'm going to treat that. And so on. Most of the colleagues will say, yeah, yeah, okay, that's what I think. Yeah. So we are we're giving substandard care to ourselves. So this is not just in Ireland. This has been found to occur in doctors in other countries, many other countries, including, of course, Malaysia. We encourage patients to treat self-limiting minor illness. But any illness beyond this should be discussed with the doctor. Am I correct? Yeah. Okay, minor URTI, cough and cold. Okay, you can treat symptomatically. Okay. Anything worse, we have to see a doctor. But many doctors, are we applying this advice to ourselves? Do we actually say, anything more serious than a URTI or minor illness, must go see a doctor? I hope all of you do. So let's picture these. Huh? You don't feel well, so you ask yourself personal questions, listen to your own answers, you examine yourself. Okay, do stethoscope and examine yourself, palpate your own abdomen. You do your own blood tests, and then you prescribe your own treatment, and then you TCA to yourself for a checkup. Sounds ridiculous, right? Yeah, but it's actually happening within the medical profession. A lot of us are guilty of doing this self treat. But if you look at it in a common sense way, it shouldn't be done this way, right? Yeah. So we are giving a lower standard than what we deliver for one patients. And there are a lot of surveys. So when these deficiencies, right, are there in among primary care doctors, we provide care for others. Same time, well, we are not well. We are listening to patient stories and dilemmas, offering advice, empathy, assessing symptoms, and make decisions which have potential to reach far-reaching effects. Okay, it makes important decisions to admit them, to give them treatment with medication, or to recommend a surgery, or to counsel them. Okay, many things we are doing for patients when we are ourselves unwell. Okay, so and then we have also responsibilities for our staff as well as the employer. Those for you, those of you for running clinics, um, somebody's audio is. Can you please help to mute? Yeah, okay. Right, thank you. And some of you are GPs, you're running your own clinics. So you have a responsibility to run the clinic yourself, right? As a business. At the same time, what if you fall sick? You take time away. So that's a challenge, isn't it? And we know now that all of us have to get CPD points every year to get our practicing certificate, annual practicing certificates. We need a minimum number of CPD points. That's now a requirement because we need to update our knowledge and skills. We can't just practice as you knew previously because it may be outdated. Yeah? You want to be contemporary or current, and you want to give the latest and safest medical treatment as far as possible. Yeah? And we need to be available as a human being as well. We have our personal needs, so we need to engage with family and friends. How many of you have missed uh, family gatherings? Okay, gatherings with friends. Well, I have many times. Okay, and what about your own needs? You have your own personal needs as well, right? Okay. So these are all the. As I mentioned, being a doctor doesn't mean you're immune to illness. Okay. You can develop the same conditions as our patients. We can have asthma. Okay, I have some colleagues who have asthma, back pain. Okay, I also get back pain occasionally. Angina. Some of my colleagues have angina, heart disease, anxiety problems. Okay, I've come across colleagues, some with depression as well. And at the same time, they had a higher incidence, these medical conditions such as suicide, depression, substance abuse, and so on. So some of you may ask me, what's wrong with treating yourself? Being a doctor, you can treat yourself, right? So there are many pitfalls. Physician heal thyself, okay? Because there's evidence. The doctors ignore or deny their own symptoms of ill health. Okay? We tend to be biased. We don't want to think ourselves as ill, so we tend to ignore or even denial. Yeah? And invariably, this causes an initial delay in diagnosis. So delayed diagnosis, delayed treatment, it's a lost time and a chance to start as early as possible, primary prevention and so on. So we need to initiate treatment as soon as possible and of the highest quality. Okay, according to guidelines, we need to apply to ourselves first. Okay, and you make just reflect back at the uh, time when you were treating patients, especially those who have medical or paramedical background. So the challenge is even greater if you become your own doctor because some of them may have their own views or opinions on treatment, right? And we know that every doctor has gaps in their medical knowledge. So we don't know everything. Okay, we may think we know a lot, but definitely all of us have gaps in our medical knowledge. So when you treat yourself and you do not get another doctor's opinion, so naturally you may make errors of judgment. Okay. Famously, we may overtreat, which always find it's true. Okay, I've come across many colleagues usually tell patients no need antibiotics. But the moment they get a sore throat, they want the strongest antibiotic, right? They want augmentin, ivermectin, and so on. But we tell our patients, oh, most likely is viral. So we tend to overtreat. Okay. We tend to give a stronger medication sometimes. And sometimes we undertreat as well. Okay, we may delay or deny that we're having cholesterol or diabetes or high blood pressure. Yeah. And it's easy to lose objectivity in treating ourselves. And at the same time, if you do not take into confidence of another doctor, okay, you will not receive their advice or explanation. And as such, you lose the opportunity to discuss treatment options and also to be comforted by a colleague or by another doctor. You're losing all these opportunities. Okay, you can't discuss options. You cannot be comforted by another. Of course, you can comfort yourself. Okay, but at times you need someone a shoulder to lean on. Okay, and as I mentioned, many doctors are reluctant to take time off work when sick, even when seriously ill. Okay, sometimes they deny the illness is present, or they want to keep up their appearances for whatever reason. Okay. In private practice, it's quite common. I mean, you're running a business, so you need to be there. Yeah, but even in other placement, they have their own reasons. They want to keep up their appearances. And sometimes, for some of us, but hopefully not all of us, okay, work becomes the sole reason for survival. Okay, it's more important to get the work done than to switch over to paying attention to yourself or one's family. There's only so much that you can do for patients and others, huh? But you need to take care of yourself. Right? It doesn't mean you need to get work done only. Okay, with the uh, ignoring yourself or your own family. And this happens, and that is why a lot of sicknesses in doctors goes unrecognized, poorly managed. Yeah. So what are the reasons? Okay, these are studies done now. So pressure of time. So why they don't go and see another doctor? Pressure of time. Okay, they have their own clinic schedule, appointments. Okay, or even other colleagues have taken off, then you are there and you are also covering for them. Sometimes not wanting to bother or busy colleagues. Your colleagues themselves also very busy. Okay, they're also very busy. They are bogged down by a lot of work. So some of us do not want to bother them. And sometimes you fear, they talk about being a hypochondriac. That means, it's nothing. Why do you think it's so serious? Kind of thing. Yeah. So they ignore it. Or sometimes the fear is being seen as unable to cope. Right? And some of us wrongly believe that we are expected to self-treat. No, it's not true. Huh? And sometimes you have a reputation to maintain, image to maintain, image of strength and success. Okay. Sometimes we may not want to meet our own patients or even neighbors, okay, or colleagues in somebody else's waiting room. Well, I've met my patients while waiting for other doctors. It's true, yeah. And sometimes we do not trust the other doctor. Okay, we think the other doctor may make a mistake, overtrade or undertrade, or give the wrong advice. So there's a lack of trust. Sometimes it can be very personal. Okay. Of course, when you're going to see another colleague or doctor, they may ask you some intimate details. Okay. As we always do with patients, we ask them the intimate details. Okay. For example, the substance abuse or sexual history or practices and so on. No? Okay. Can be very intimate. Okay, private practice, if you shut down, your business is down, livelihood is affected. That is true. And so they have overhead, salaries, and you have to take care of your other staff. Okay. What about treating another doctor? Is it easy? So our attitudes and norms as well makes it difficult to treat another doctor. Why? What are those attitudes? So we always say doctors themselves are difficult patients. Why? Because they may not follow us and so on. So when you reverse the role, okay, when you consider yourself as a patient, then you may want to describe your difficulties. Okay, um, being a patient or taking another doctor's advice, or taking somebody else's decision. Okay, we are forced to do that. No? If you are a patient, and sometimes this comes in two ways. Huh? So one doctor says, the other one whom they attended is embarrassed to talk about it, or dismissive of the advice, or not very communicative. They tend to hide or downplay a lot of things. And doctors have been patients commented that their doctors made assumptions what they might expect from a consultation. So not every doctor attends a doctor wants an investigation or prescription. Sometimes they just want a reassurance or a counselor, or just to discuss options. Not everybody wants medication. Not everybody wants an investigation. Okay, and so on. But then the other doctor may feel that, oh, this colleague of mine is seeing me, so I must give some medication, some treatment or investigation. Not necessarily, as I mentioned. So we may just want simple reassurance, just like other patients. Okay, so doctors would treat other doctors as patients. We know that the consultation is different. Sometimes we are concerned that the patient knows more about their condition. They may be afraid to ask specific questions or embarrassed about writing a prescription and so on. And thinking that most doctors write their own prescriptions anyway, which is not necessarily true. And so they may be reluctant to give same advice that we give to other patients in case it affects the relationship. Okay. So how to resolve this? We need to overcome inaction. Okay. So with respect to colleagues, if a colleague appears to have a health problem, there's a tendency not to offer assistance or advice. May not necessarily be true, but this pattern has been identified in some countries. So when colleague is unwell, there's no action because we think the doctor knows best. They probably try to deal with it themselves, even though not successful. Fear of insulting, okay. We ask them and we think that the doctor may be offended. Yeah? And sometimes we just don't want to open a can of worms. Okay, we don't want to have anything to do with the other doctor because we ourselves are so busy. We're going to be so busybody or sabo, ask them. So some of them just avoid this issue totally. Right. So, for example, if their appearance is deteriorating for whatever reason, weight loss, maybe due to some physical illness, or mental illness, depression, and so on. Okay, some of them do not want to know anything, just don't want to deal with it. But with respect to yourself, if you are unwell or concerned about your health in any way, your best advice to go and see another primary care doctor if you do not have one. Okay. And so there's some colleges or practice, uh, I mean, what do you call medical centers, what do you call programs. This one is in Ireland. They wanted to challenge the current norms, give an alternative. So they set up a ICGP, Health in Practice program. So what is this? So they have an education information service, healthcare networks, and they have a committee on this. So this one deals with giving education information to the colleagues, networks, and so on. And this includes GPs, psychiatrists, counselors, psychotherapists, psychologists, occupational physicians. So they all experienced independent practitioners, okay, not necessarily their own employees. So they're available. You can access them directly or through telephone helpline. Okay. This is very important. It'd be good we have this in Malaysia, right? Yeah. So how is this? I'll just go through the different categories of doctors. On the extreme left, okay, is the healthy doctors. So for those who are healthy, we just continue to promote and maintain healthy lifestyle options. Okay, we give education, okay, from medical students to until those who are even retired. What about those doctors at risk? There may be some past history of some medical condition and so on, or substance abuse, mental illness, and so on. We try to reduce exposure to the avoidable minimum, okay, and interventions to prevent them actually to develop these conditions. Those with symptoms or concerns, best to diagnose early and intervene. So this one, of course, we need to increase our skills and knowledge, and also looking out actively, yeah, for conditions in other colleagues. And of course, those who are already having established conditions, physical and mental illness. Okay, so we aim to provide treatment, recovery, or minimize disability. Yeah. So primary, secondary, and tertiary prevention is there for this. Of this. And then structured services and follow-up care for them. So we are merely individual society, right? We also have our family and friends. We have a working group, and that itself is an organization. Our family and friends are in a local community. So there are many societal expectations, either economically, politically, culturally, and socially. Okay, there are many expectations for doctors. So I'm going to come to this section. I'll ask you all these questions. Did you ever carry out a medical examination yourself? Did you do it yourself? Or did you visit another clinic to do it? Any self medication? Did you consult another family doctor? Or spend time on your own health? Okay. Just today, the Minister of Health was saying that each family to have one family doctor. Today's uh, news. Okay. So do you have your own? You are being a family doctor, but do you have your own doctor? Okay. This one is in substance abuse. And some studies showing that doctors also have substance abuse, alcohol consumption, right, and so on. Huh? So let's go to the medical ethics part of doctors seeking treatment from others. So we have our own individual autonomy, okay, to decide on things whether we want to seek treatment and to seek medication or certain procedure. Right? We can decide for ourselves. So we need to have mutual respect for individual autonomy. We cannot dominate the other. Let them make their own uh, decision, yeah? Shared decision. So if there's a paternalism, that means we are the one deciding for what treatment, then it will not be ideal. So how would the doctor-patient relationship be? Well, let me take a typical primary care clinic, huh? Ministry of Health, even GP. So here the physician control is low. You can't decide how many patients you're going to see, what medication you can give, or what investigation, whatever is available with the limitations, only then you can give. So no matter how many patients, you need to clear them all. Okay, Ministry of Health is always good service. What about the patient? Their control is low as well. They can't usually choose their doctor or the type of treatment or medication or procedure and so on. No? So both sides control is low, right? But sometimes in the private sector, patients may have a high control because they are paying upfront. Okay, so when they pay, so they may demand, okay, for certain investigations or certain medications. So this is also called consumerism. Okay, this time control because the patient is can't really control because the patient's paying, so he can demand a lot of things. Okay, okay. So what about situations where the physician control is high and patient control is low? That's paternalism. No? That means physician is calling the shots. whatever he wants to investigate or diagnose and treat. So he's a patient, tak boleh tanya, doctor knows best. So this called paternalism, right? And all these three types of relationship is not very healthy. We would ideally aim to go for mutuality. So both sides have high control. The patient has high control. Okay, you can choose what to investigate, medicate, and so on. And the patient has a high control as well. Okay, he can also choose what to accept, what to investigate, and what procedure, and so on. So when both these two meet, then it is called mutuality. So this is the ideal situation that we would like among doctors, mutuality. So you make a shared decision, right? Not one party over the other, not one party demanding, such as in consumerism, or one party is talking down or deciding everything as in paternalism. Okay, so do we need element of paternalism? I would definitely not encourage that. Okay. So, but what about patient's autonomy? Does it abrogate your duties? Not really. It's their choice end of the day. Right? We can only advise and encourage and uh, give a best opinion. No? So, but we also need to be aware. When we are patients, when we are the patient, we always wish to organize elements of own care. I've seen many of my colleagues, okay, they want to see their one favorite doctor and so on. No? And the problem is they may also self-prescribe. Okay, so we should discourage this self-prescribing, uh, but we need to be encourage. I mean, we need to encourage them to refer themselves, well, or we can give a referral for opinions and investigations. And doctors need a lot of reassurance. Let me tell you that a lot more than even other patients, because we are at a very what do you call critical juncture, right? Sensitive aspect where we are caring for patients as well. So sometimes we are also having a lot of fear, okay, because we see what things can go wrong, how things can turn out, you know, worst case scenario. So the doctors will need a lot of reassurance as well. And we need to be aware that they may present late in an illness, okay, even hypertension, diabetes, cancers, and so on. Recently, I've had a colleague who developed cancer. And be aware that doctors may have a high level of denial. Okay? They may even dispute the diagnosis, especially if it involves sensitive aspects such as mental illness, substance abuse, okay, drugs, alcohol, STDs, okay, because it goes into the private sexual history and so on, okay, or even their preferences and so on. So they may actually not tell the whole truth, okay, and sometimes it may lead to sexually transmissible infections, any form of domestic violence, and even forensic issues. Forensic means later on they pass on. But I must say, I do have some medical doctors as well and follow up for STDs on substance abuse, rarely, okay, but there are mental illness, certainly, right? And so these doctor patients may misinterpret the symptoms, have an incorrect self diagnosis, but they may still function at a high level, even when physically, cognitively, or mentally unwell until the very late stage or very serious stage. So just imagine this: if you see a patient and then you do a family chat, right? Also, we do a family chat. Yeah. So if you are the patient and you are treating yourself, so who's to take history? Are you going to write down his history yourself? Not really, isn't it? Sounds ridiculous, right? So if you avoid all this, you do not go and see another doctor, you self-treat and so on, in denial or delayed and so on. There are many consequences. So what are these consequences? We end up with fatigue, poor work performance, okay, because you're unwell, mental health issues because maybe undiagnosed or wrongly diagnosed, accidents, okay, you're too tired, you do not want to seek help, silence, denial, okay, all this. So until the worst case scenario, they lead to accidents, burnout, even like death. Yeah. So let me show you one study that was conducted in Malaysia. It was looking at the self-care and self-medication. So they did among many agro doctors. Generally, is both male and female doctors. Some were from Malaysia, some overseas. They are undergraduate medical degree, and age majority between 31 to 40, and public and private. So majority in the public sector. So they're asking about health problems, whether they have had any medical problems. So about 39 percent said yes. So say about 40% said yes. And then most of them between 1 to 5 times they took medication, and not taking medication is less. Self medication, quite a number, about 26%. No? Okay. Chronic medical conditions, about 18%. Emissions, about 21%. So there are quite a number of doctors seeking treatment. No? Medication with analgesic, self treatment is antihistamine, antibiotic, NSAIDs, antihypertensive, less. Usually they go and see another doctor, which is good. Anti-diabetic, anti-lipid is less. Huh? Yeah. But the other common ones, a lot of them are self-treating. Do they consult another family physician? The vast majority, 80%, do not. And how often do they communicate? Consult? Very small number, only about 30%. Okay. Do they take care of their own family members? Yes, vast majority take care of their own family members. And is your family member being looked after by different specialists? Yes, true also. Yeah. So what's your perception? About half think they need, okay, a personal family physician. About 3/4 think the family needs a personal family physician. So family doctor is very, very important. So self-medication, okay, no difference in the type of, okay, in the beliefs and all, nothing is significantly different. Okay, whether they should treat analgesics, antibiotics, and so on. Okay, it's having their own doctor also not very different, but quite a number of difference. Self-treatment versus anti-hypertensive. So it's anti-lipid and so on. That's significant. And what is it significant? Here is the age. Okay, total years of practice versus keeping a promise for himself or herself. So the older a doctor gets, then more they tend to seek help with another colleague. So what about you? Do you have your own doctor? Yeah, I have to ask you all. You have your own family doctor? Maybe some of you can put it in the chat box. No, no family doctor. FMS. Okay, FMS is a good idea. If you have an FMS in the clinic, get at least a more senior doctor there to look into, your own condition. I'll promote your clinic FMS actually to be your family doctor if you are comfortable, with the doctor. Or you want privacy, then you may want to see another colleague in another clinic. Okay, if it's very personal or you need privacy, then but it's good to get a doctor, right? As long as you trust the doctor, preferably a more senior, a more experienced, and a better version of yourself. No? Right. So some of you have mentors, guidance, Okay, one of you have got your own family doctor. Okay, maybe a GP. Yeah, it's fine. At least you got somebody to discuss and reflect on your condition. Yeah? Okay, but how many of you think you need a family doctor? Agree that you need a personal doctor. Since the topic is coming to end, my talk is going to end soon. We'll run a poll. Huh? How many agree you need a family doctor? Agree. Huh? Okay, I see most of you agree. Most needed. Okay. Okay, that's good. I'm not sure if you're actually doing it, but at least I hope I changed your mind in case you didn't have a doctor. Yeah, so do keep a personal doctor for yourselves. Huh? For kids only. Huh? Okay. Okay. I'm sure a lot of you care for your kids. Okay. But you must also care for yourself. Huh? Right. A healthy doctor is a healthy patient, right? And a healthy parent is also a healthy child. Huh? Don't forget that. Okay. So do get a personal doctor for yourself. Kids come first. Okay. Okay, true. But remember in the plane, I mean, if you go on the plane, so usually there's a security stewardess will come and show you how to, you know, the security guidance of the plane. And so one of it will say if the oxygen is lacking and the mask will drop down. And do you remember what they say? They say, please attend to yourselves before you attend to your kids, huh? Right? Okay. Okay. Family always first. Okay. All right. But you can do it together. Okay. Okay. Right. Okay. I'll go on to the next slide. Okay. Health of doctors. This is summary from the Royal Australian College of Physicians. Executive summary. Yeah? So doctors, like everyone else, need to look after their own health. As an important component of maintaining their own health, should have their own GP and undertake regular health checks. While doctors as a group enjoy comparatively good physical health, certain characteristics of the medical profession predispose doctors to specific health risks, which I've already mentioned earlier. Historically, yeah, and it is still happening, medical professional culture encourage doctors to sacrifice their own health for accepted practices such as working long hours, taking work home. Well, it's still happening. We can't totally avoid it. Okay. So increasingly efforts are being made to address counterproductive workplace behaviors. Workplace bullying, of course, is no longer tolerated. We can have differences in opinion, yeah, as far as treatment or how situations are handled in clinic or in workplace, but that doesn't mean you need to bully one another, right? Medical training presents an opportunity to increase healthy practices. Since we learn a lot about medicine, we should have a lot more knowledge than the others. So we should have awareness of warning signs, strategies to manage stress. Okay. But of course, we want this to be translated into our own habits, lifelong protective habits, and promote resilience. And for this, we need continuing professional development. So we want to have opportunity to engage with doctors regarding this issue of maintaining the own health, such as this lecture. And so we know that we acknowledge that when healthcare concerns arise for doctors, they may be reluctant to seek appropriate medical care. They may be uncomfortable assuming the role of patients. They opt instead to treat themselves. Well, we can, but only for the minor, smallest, or the most minor of illnesses. Anything else, we should get a colleague. Yeah? Regulatory frameworks are important consideration. Okay, so in Malaysia, I think we do not have this. Right? In some other countries, they have that. They have a network support. Doctors are encouraged to seek independent medical consultations. Okay, and there's a recognition that we need more skill sets to help doctors treat other doctors more effectively. Hopefully, there'll be future training on this. And so these avenues are available in some places such as Australia, New Zealand, and so on. And okay, so they have initiatives among these countries. Right. Okay, so I'll come to the final slide, I think. So 10 ways to be a healthy doctor. Have your own GP or own doctor, in a way, family doctor as well. Either one. Avoid taking work home as far as possible. May not be totally avoidable. I'm guilty of that as well. But try as much as possible to avoid taking work home. Have a buffer zone between work and home. Okay, but I think in this age of social media, WhatsApp and all, it is becoming increasingly blur, right? Work and home. Okay, because you are reachable all times. Huh? Okay, many years ago, we do not have this. So when you leave work, there's no way of contacting the doctor. But now we can reach out to each other very easily. Yeah? But try to have a buffer zone and taking control of your working hours. Some examples like scheduling breaks. Okay, during work, maybe your tea break, a quick one. Okay, a lunch break or a quick one, and so on. Take some days off. Okay, we've been working all day, or all week, or all month, or even years, and then you take some days off. Okay, and strike a balance. Paid work and demands of your job. Okay, you do not want to overdo it. Okay, you put in the right amount of effort into your work, right? Not overly, and try to plan holidays ahead. Okay, months ahead, and tell your family and your colleagues as well. You plan ahead, then you won't stress them out by taking emergency leave, right? And anyway, those in the government, you need to apply early if you want to go overseas and those kind of things. And again, make realistic schedules and not overcommitting yourself. So sometimes you have to learn to say no, right? If your boss gives you more work, be realistic. I mean, if it is your work, yes, lah. But if it's too much, then you have to voice it out. Manage your work environment. Okay, so you may need some time and skills. You can discuss with your bosses for better work conditions. Okay, work environment, the clinic setup, and so on. No? Your desk, your chairs, okay, AT support, uh, timings, breaks, timings, and so on. And use your colleagues for support. Okay, some of us are not optimizing our colleagues. They can be a great support to you. Yeah. And so you need to maintain working relationships with your partner and friends as well. And don't forget, not just family and all, you also need time on your own, such as relaxation. Okay, you may be spending time alone, maybe a walk in nature, the park, okay, some massage or music, whatever, movie. Yeah. Okay. So nothing wrong with it. You're not less of a doctor, no? Right. And don't forget humor as well. It's a great way to release stress. Huh? So key messages, dear colleagues, we need to optimize our physical and mental health so that we can serve patients better, and your family will benefit too from a better you and healthier you. Huh? All doctors should have a general practitioner or a family doctor. Try not to self-treat or self-prescribe. No treat or prescribe a family and friends because we may be biased. Okay, we may undertreat or overtreat or wrongly treat. Okay, sometimes it's out of convenience, out of respect, okay, out of compliance to our favor and so on, but it may not lead to the best outcome, right? Those with family and so on, except for the minor of illnesses, yeah. But try to get a colleague to treat, okay, and try to be alert to the signs of stress and burnout in yourself and others. And if you got a health concern, always seek help. And what are the signs of burnout? You may have emotional exhaustion, okay, emotionally unavailable. Huh? Cynicism, you start criticizing others or looking at the negative side, okay. And your colleagues will say, oh, this one is very toxic and so on. No? Cynicism. Okay. Actually, it can be a sign of burnout in the staff. Okay. So if you see a staff that you consider as toxic, maybe that person is burned out, having stress. Okay. Perceived clinically ineffectiveness. Okay. So sometimes we may be clinically not so good in our work because we can make the best decision when we are burnt out. And sometimes we feel a sense of depersonalization in the relationship. So you don't feel it's worthwhile, your relationship with your co-workers or patients or work. You kind of, what do you call, zoned out, okay? Yeah, because you're burnt out. That's the reason. There's some questionnaires as well for this burnout, okay? Can Google them up, okay? Can have it. And so, a doctor that treats himself as a fool for a patient. Am I correct? Did I say this? Actually, it's not me. It's mentioned by Sir William Osler, okay, a great physician. Okay, um, is a, okay, whom you might have heard of during your undergraduate days. He was very popular. Right. So with that, I conclude. Thank you for listening. These are some of my references. Okay, and Q&A is promised by Dr. Naveen. So I'll stop sharing.
Yeah, thank you very much, Dr. Paran. Any questions you have? We have some time.
Yeah.
Any
Either my
questions?
either my lecture was made it totally clear or they're totally clueless.
Yeah,
There's no question there. I
okay,
hope it's the other way around.
okay. Never mind. If later on you think of a question, you can put the question, the link, and I will send the link to, I mean, the questions to Dr. Paran to be answered. Okay. All right. Okay. So I guess the lecture in the end say that you should prioritize your health also so that you can treat your patient. Even though I see that think a lot of people put their kids first, I guess you have to put yourself first lah, then your kids, because you don't remain healthy, how you take care of your family, I guess lah. Don't forget your
Yeah.
husband and wife also. They're also equally
Yes,
important.
yes. We need to put ourselves first at times. Yes, you have to be a bit selfish.
Yeah. Yes, you need to put. Okay. Okay, that's fine. Okay, so if no questions, I'd like to thank Dr. Paran. Okay, and I'll get back to you, Dr. Paran.
Okay,
Okay,
all right.
and thank you very much.
Okay, all right. Bye bye, everyone. Have a good day. Have a good
Okay,
rest.
thank you.
Okay,
Bye.
take care of yourself. Okay.
Okay, so now we left one more lecture. We'll wait for Dr. Prof. Chong actually to come. When she comes, we'll start. So maybe y'all can hang around. Um, she may come anytime between 3:05 to 3:15. Once she's here, we can start. Okay. So yeah, so you can go for a short break. Okay. But just be alert lah when it's starting. Okay. Thank you. Hi, good afternoon. Prof. Chong, can you hear me?
Yes, I can hear. Naveen, can you hear me?
Yes, we can. I can hear you. You want to start earlier a bit?
We can start now. Is if
Uh,
everyone already here, then we can start.
yeah, I think most of them are there. Here you can start lah. So just let me just briefly introduce. So Prof. Cheong, she is at the Department of Family Medicine at the Faculty of Medicine and Health Sciences, UPM, similar to me. Okay, she's also quite senior in this field. Okay, today she will deliver your lecture on practice audit. So please listen carefully, and hopefully in the future you can carry out some audit, which you actually can publish as an article later in the Malaysian Family Physician. Okay, over to you, Prof. Cheong.
Okay, yeah. Thank you, Naveen, for the kind introductions. Okay, so hopefully everyone still have some can have some concentration for this lecture since it's the last lecture. Let me share the slide. Okay, can see the screen, right? Can see?
Yes, can.
Okay, let me go to this one slideshow. Okay, so I think everyone will be quite tired, so we will continue lah. Okay, with if anything, if you're unable to hear, I think please put in the chat box or whatever, because sometimes you have some technical issue for online. Okay, so for today's sharing, I will go through with you the clinical audit, the definitions, classification, types, audit cycle, and how to do a clinical audit. Okay, so what is clinical audit? Okay, so I put up two definitions, which is quite old definitions, but the meaning will be the same. So the first one is a Meringa, which is say that is an attempt to improve, okay, the quality of care. Okay, let me this one. Okay, quality of care of medical care by measuring the performance of those providing that care. So that means that is measuring what the healthcare providers been doing lah. Okay, so by considering the performance in relation to desired standard and by improving on this performance. So I mean, all of us, we know that we have protocol, we have guideline to adhere. So this will be considered as the standard, desired standard. And so we will see whether our care is in line to that. Okay, whereas the NICE guideline had mentioned that quality improvement is a quality improvement process that seeks to improve patient care and outcomes through systemic review of care against explicit criteria and the review of change. So in this one, it more emphasized on the method. Okay, it's telling us that the outcome which we are going to measure, which are going to review, is a systemic review. So there is a step with it, and we have a criteria which is very explicit, means that which we know lah, is either from our protocol or guideline, and we want to see whether we can change further to have a better care. Right, so what do we mean by quality of care? So basically, we have classified into two, which the first one will be patients' expectations and satisfactions. So it could be after seeing you, the patients feel that they are being happy with the consultations. They feel that their problems has been discussed. Okay, so the second one will be patients' outcome, morbidity and mortality, which is the more objective one. In terms of when we see diabetes patients, we think that our management will lead them to reduce their morbidity in terms of complications, admission to hospitals, and also mortality. So then we ask ourselves, why we need to go for this clinical audit? Okay, so this clinical audit actually is served as a quality assurance tool. Okay, it provides the results for us to see, and then by having the results, when we see our results, we can change our behavior. Okay, so just like if we go for exam is serving as a tool to help to see the students performance, what they know. So if they are not scoring well, then they will think what is the place they need to improve lah. So clinical audit serves the same purpose. It is a tool for us to measure our performance and for us to see the results, and we will see whether we can improve or not. So without the measurement, we do not know how good we are doing, right? And the second point is, by having this, the second point is, whatever you have, the knowledge you have, after you graduate after you graduate from medical school, and now during your postgraduate training, okay, you have certain knowledge and you know what to do to the patients, but it doesn't mean that you will translate all knowledge to your patients. Okay, basically there's a lot of things to consider when from the knowledge to the implementation, because if you have lots of barriers, okay, to implement certain thing, then you unable to translate the knowledge to the clinical practice. Okay, so it means that the knowledge is not equal to clinical competence, right? So we need the clinical audits results to help us to see that what is happening, right? Okay, this is to show that they are authors to have the researcher have go through the systematic review to look at the audit and feedbacks and their effects to the healthcare outcomes. Okay, the results show that the audit and feedback generally leads to small but potentially important improvement in professional practice. Okay, the effectiveness of audit and feedback seems to depend on baseline performance and how the feedback is provided. Okay, to provide a feedback which is not judgmental and will be very important for the team to see how they are going to proceed further. Okay, of course, the baseline, every clinics will have different baseline of performance. Okay, if simply we can see that if you are poor performance from the beginning, after you implement the audit, you will have higher chances to improve lah. Just like when you score 90, then your improvement, you need to score above 90, which is much more difficult if you score 60 at the beginning and you want to score more than 60 subsequently. Okay, so clinical audits, we have 3 types of clinical audits here. External audits mean the outsider body who come and our organizations and audit us, like the CRIM, okay, come and audit your clinical management. Peer audits basically means that your FMS or others PIC, clinic in charge from other clinic come and audit on your clinic. Okay, it's considered peer audits. Whereas self-audits is the initiative from yourself to audit, to look at the improvement of the clinic itself by the same like same team in the clinic, not depend on other people to audit on you. Right, so we have classification the clinical audit to 3 types, which is a structure, audit on the structure, audit on the process, and audit on the outcome. Okay, what do we mean by audit on the structure? Okay, means that we look at the quantity and types of services which we can count. Yeah, for example, doctor to patient ratios, the resource allocation, for example, how many HbA1c reagent you have, yeah, and recording system. Okay, this one is a physical structure which you can see. Second, audit on the process is you look at what is done to the patients. Okay, for example, whether the doctor examine the patient's eye every visit, okay, or examine taking the blood pressure measurement every visit. Okay, so this is seeing what we have done to the patients. Okay, whether you have referred patients appropriately or whether we educate the patients accordingly. Okay, outcomes. Outcome is the eventual results of the intervention. Okay, our management is an intervention. The medication we prescribe, the team, let's say your diabetes nurse who give the educations, you give the education. All these are the interventions to the patient. Okay, so the outcome is one to see that what is the eventual results of this lah. So for example, okay, is how many patients under your care have the mortality or admit to hospitals, okay, after putting on the management, on the medication, okay? So all patients satisfied or not after you have communicate with them. Whether the cost has been reduced after we have managed the patients accordingly. Okay, It's not easy to measure, for especially you want to look at the cost of care. Okay, you want to look at the mortality or morbidity. You really need to have that in your hand. No, unless you will document properly. If not, then it's very difficult for us to get the informations to know this. Okay, and it's influenced by many factors. Okay, if you have give the patient the appropriate medication and you have counseled the patient properly, and sometimes you don't see the good results on this patient, you know why? Okay, because patients basically not adhere to what you have been prescribed to them. They don't believe it, they don't take it, right? So it means that the factors is not only on you, but whereas in the process we already audit what we have done to the patients and we have done correctly, but the outcome might not be desirable because it influenced by many factors. All right. So now we have some quizzes, to evaluate that whether you have understand what just now what I mentioned, what you mean by audit of structure, process, or outcome, for the each questions below. Okay. You like to let's say you would like to conduct an audit on hypertension care in your clinic. So now I give you this. All right. So can you please scan this and try to answer it? Okay, what is the proportions of hypertension patient that has been screened for cardiovascular risk factors? So for this statement, which we want to see, patients has been screened for cardiovascular risk factor. Is it audit on structure, audit on process, or audit on outcome? Okay, can you please screen, can you please answer it? And we want to see whether you will understand or not, right? Yeah, so, yeah. Okay, so I think about 55 of you, so more to answer to come. All right, so what is the proportion of hypertension patient that has been screened for cardiovascular risk factor? Okay, when we screen for cardiovascular risk factor, is what we have done to the patients. Okay, so that means that this is the audit on process. Okay, so about 58% of you, which is correctly answer. Okay, so what we done, we examine the patient. You screen for cardiovascular is you examine the patient. So this will be more to the audit on the process. Okay, so now we go to the next question. Okay, what is the proportions of patient that has his or her BP checked during each follow-up session? Okay, again, we look at the questions carefully. Okay, so is we are asking how many patients has been checked her blood their blood pressure lah. Okay, so when you check the blood pressure is what you examine the patient, whether you taking the blood pressure or not. So this is an audit of process. If audit of structure, we might want to ask, no, whether every consultation room have a BP machine. Okay, so because BP machine, BP set is a is is equipment, right, which you can count. So that will be the structure. But now you are whether you have checked, you have examined the patient's blood pressure or not. So this will be more to the process, audit of the process. Okay, of course this is not yet outcome yet, because the outcome, as I say, we are measuring the mortality or morbidity, or whether they are control or not control, then that will be the outcome. So this is not the structure. So don't it's quite easy, because the structure is the thing, they are physical thing for you to count and for you to see. That is a structure you want to have. But this is we measuring people's BP. So this is what you know, the BP set already there, whether you measure, not measure, whether you examine, not examine the blood pressure. So that will be on the process. No, if we ask about whether you have adequate BP set, then there will be audit on the structure. Okay. Okay, only 2 questions. I thought I have 3 questions. Let me see. Okay, this question. What is the proportion of patients has achieved BP control? Okay, that's good. Yeah, so everyone, I think like everyone has wake up now. That's very good. Yes, so when we want to see what is the results of your intervention, okay? So what you want to see is a BP control or develop or complication and all those lah. Okay, so this is the audit on the outcome. Okay, definitely not structure. So maybe you accidentally key in wrongly. I I hope. All right. Okay, so right. Okay, so let's go to the so now, yeah, hopefully everyone already like little bit more wake up, because we are going to go to the more important section, which is how to perform the clinical audit. Right, so clinical audit, here we follow the clinical audit cycle from choosing the topic, okay, go to agree criteria, observe the practice, evaluate information, plan care, okay? So we will go one by one. Okay, what we mean by choosing a topic, okay? It's quite simple as what the title say, is what do we want to review, okay? How do you choose a topic? Okay, of course, this topic must be interesting and important to you in the clinic. If not, you will not want to take it up, right? And also important, when you choose the topic, that it must be able to measure, okay? And then you think it's possible for change lah. If it's unable to measure, then we're unable to get the result. So that or sometimes you can get the result, you think this thing is not able to change at all, because everything already fixed by the authority, and you are unable to change at all, then no point you go for the audit as well. You waste your time. Okay, so how you get the topics? Usually, we say it must be important, so it might be have a lot of complaints coming in. Like many years ago, everyone is complaining about the waiting hours, so there is the clinical audit on the waiting time. Okay, so then you see how to intervene to shorten the waiting time. Okay, and some critical incident reports, like maternal mortality, neonatal mortality, all this, when it happen, so-called too many, then you're thinking, no, what's wrong with your management? And you want to have a closer look on it. Okay. Sometimes it's a feedback, okay, from patient story. Of course, unlikely here to be focus groups is some research method to have a group of people who discuss on it. Yeah. Or from your direct observation of the care. Okay, if you see, okay, this diabetes, always patient do not have HbA1c always very high and medication not optimized, then you see something wrong. Okay, so you want to carry on with the clinical audit. Okay, so I want to give you some example of audit on diabetes, okay, among a diabetes patient. Okay, agree on criteria. So from here onward, we will use diabetes as an example lah. So what is agree on the criteria? What do we want to achieve? So just now we just have a topic, okay, want to look at the diabetes care in our clinic. But what is exactly we want to look into? Okay, so the indicator and the criteria are what we means here lah. So this indicator must be have the impact on the quality of care. Okay, and we develop the criteria to define what we are trying to do precisely, and then later we set a target level of performance. Okay, so how do we know all this indicator have the impact, okay, to the patient and should be looking into? Okay, of course, we have a lot of guidelines or protocol which guide us. Okay, so let me show you the example, okay, audit on structure. Okay, so let's say if we, from this diabetes care, what the structure you think is important, okay, in your clinic to facilitate you to deliver the care. Okay, for example, diabetic registry. Okay, diabetic registry important because you can capture how many patients, so that then you know how many budget you need to ask for your all the tests you need to do. Okay, and how many doctor you need to allocate to see the patient in the follow-up day, things like that. That's why it have an impact. Yeah, so we will want the diabetes registry to set up, okay, in a clinic. Okay, if you are looking at the audit in a district, of course you want all clinics have a diabetes registry. Okay, that is our target, right? So reminder system. We know that reminder system is good to have. If patients do not turn up, we should remind the patients to come in so that they won't default. Okay, so that is the importance behind the indicator lah. Then the criteria is presence of reminder system, whether yes or no, that's all. Okay, and the fundoscopy, fundoscopy, but now probably you want to have a fundo camera, okay, either in your clinic, things like that. Okay, so that you can set the indicator based on what do you think the important, okay, structure you need to have to facilitate your management of the diabetes patient. Yeah, and how many you want to have, that you can state it in your criteria. And then of course the target level of performance is whether you want all like funded camera, you cannot have all, maybe one district have one funded cameras, things like that. Okay, so now we go to the process. That is just a structure. Okay, the process, we are thinking that, okay, what's the thing we need to do for the patient? As just now we have mentioned, okay, I think we should order the fasting blood sugar every visit if you think that is appropriate, or we should do a random dextrose sticks every visit. Okay, for HbA1c, we think appropriate 6 months or 3 months. Okay, you should have that. And lipid profile, you think if you done once every year will be adequate, or you also want to do one every 6 months. Fit examinations for diabetic patient, examine done every year. Okay, so you can see that the indicator is the things which you think that you should do for the patient, but the criteria have mentioned it very specifically, how much, how frequent, you want to do. Okay, whereas the target performance, you can set based on your previous experience of your clinic audit, or you can search the literature whether have a similar people who publish similar, health clinic which have already published their clinical audit result, so you can give a performance which you want to try to achieve lah. Sometimes, of course, you can say that ultimately you want to reach 100%, but then for beginning, you would not to demoralize you so much that because thing is not adequate yet, you might want to reach certain level first, then after that improve it further lah. That's why you can see the target of performance, some at 80, 50, 70, 50, things like that, which is in the team. You need to decide, the management in the team, the FMS with the doctors, with the your lab technicians, together and see what is your performance you think is appropriate at this moment, and then slowly you want to improve it further. Okay, audit on outcome for diabetes patients. Of course, we want it to be controlled. So that's why we want to see how many of our patients have control of fasting blood sugar, HbA1c, or control of the lipid profile, and so on. Okay, so that is the outcome we are trying to look at. Of course, you also can see how many patients have complications, peripheral neuropathy, the having stroke, having heart problems. Okay, you can audit on that as well. But the complications sometimes, because it take many years to establish, it might not due to your management in your clinic lah. All right, so next, after you have choose the indicator and criteria accordingly, maybe based on your protocol or based on the guideline, then you get ready all that. You have some data collection form with you. Then you can go for observe the practice and do some data collection. Okay, what exactly are we doing? So you want to collect the data to see what exactly are we doing. Okay, first, you have set all those, but now you have to think back who you want to include. Who are the diabetes patient or record you want to include? Okay, so you have some inclusion and exclusion criteria. Remember, you are now audit on the clinic performance. Okay, it means that the patient have followed up with you for some times, which you have enough time to provide the appropriate management, then only can justify these results is your clinic doing and your clinic performance. So usually we would like to include the patient who have followed up with you for at least maybe a year or so lah. Because if they are newly diagnosed or they are just come in refer from elsewhere to your clinic, you have not have enough time to do all the tests or all the examination, all the process you want to help this patient, then it's not fair for you. Then the result will show you are very underperformance, not because the staff not doing, but the staff do not have the adequate time to implement what they have to implement. Because we know that when we follow up the patient, we cannot do everything in one setting. We are doing it over a few settings. Okay, so that is the important thing lah, which we want to consider when we include who should we audit on, who are the patients we are audit on. Of course, sometimes, so though we have target population, but eligible patients are very important. You want to see who are eligible so that those patients are reflect what you have doing lah. Okay, what you have implement the management. Okay, then next, after you have decided the inclusion exclusion criteria, then you want to go and sample the patient. if your clinic is very small, let's say you only have 100 diabetes record, so you might want to take all, that's fine. But now a lot of clinic, they are very big clinic and they have thousands or 2,000 of diabetes patient under their follow-up. So in that case, it's quite very taxing for them to take all patient. So that you need to do some sampling method, okay? So if you have undergone the research module, you know that if you want to get a representative data or representative sample, you need to do the randomized sampling. Okay, either it's simple random sampling or systematic sampling, which if you have a diabetes registry book, will be easy for you to do simple random sampling. If not, then you can do systematic sampling. That means that when the patient, you estimate how many patients come, in your 3-month follow-up, you want to carry out, 3 months, let's say, and after 3 months, you see the patient will repeat. Then 3 months, then you estimate how many patients. Then you want to take, let's say from there, you want to take 100 or 200. So you get the fraction. Then you can see one in how many, okay? One in how many patients you want to get, okay? Like you have 1,000, you want to take 100, so it will be 1 in 10. No, every 1 in 10 patients you are going to take for your result data collection. Okay, but of course, the first patient from 1 to 10, you need to use a simple random method lah to get who is the first patient you are going to start lah. If you put 1 to 10 number in a box, you take out is number 6. That means the first patient is the 6 patients and the subsequent one will be 16 and so on lah. Okay, so we are doing the audit, if we do not take all the patients, we should try to sample a representative data. Okay, then go ahead and audit it, follow your criteria just now. Okay, look at patient number 1. If we say fasting blood sugar every visit, then we look at the record for the 1 year. Is it every visit they have do a fasting blood sugar or not? Then you will see yes or no. Okay, so later you can get the proportion of patients who have done every visit for your process. Okay, so that is how you do the data collection. So after the data collection, next will be the evaluate the information. Okay, is our performance in line with our what we target we set before? All right. So this is the interesting part. Okay, when you have a collect all the data, same like the research, you need to key in all your data. Then later, but the mathematical calculation is very simple because basically it just yes or no, how many have done accordingly, how many have achieved the target accordingly. Then you can easily calculate the proportion. Then we will compare our proportion with our target performance, which we set earlier, and see whether we have achieved our target or not. Okay, so we can see that some of it, HbA1c is 60%. It looks good. You have achieved the target, but even that is achieved now, but you will see how you want to get it higher lah, right? So 30% is really low. So you will see what happening, but why we are unable to do even, but we only do 30%. But only 30% of the patients have undergone the lipid profile. All right. So we compare our data with earlier defined targets, which we showed you all before. Compare within our practice or similar practice. Okay. After that, we go to provide feedback. So go to the next step will be the plan care. What must we change and how can we achieve change? Okay, so we already have the result. Then we can see what we must change now and how can we change further. So as you say, we need to get all our team to come in lah. So from beginning, when you want to plan a clinical audit, we need to have a team. Okay, we'll see who are those people who involved in our management of diabetes, the FMS, the MO, the nurses, some of the nurses, and the lab technicians, so-called. Okay, so then when we show the result at that time, then everyone need to be there. Yeah, so we can brainstorming and asking everyone, okay, why do you think that the fasting lipid profile only have 30%? You know, so listen to what they are telling you, okay? What is the problem the nurses have? What is the problem the doctor has? What's the problem a lab technician has? So in that case, then you list down all the problems you have and see how can you solve it. Okay, if the doctor say, I don't know, that means that this is the clinical competence or knowledge skill issue because the doctor didn't order. That's why no one get the test. Okay, then you can have a CME or courses for them. Okay, if the lab technician inform you that doctors, all the doctor have already ordered the test, but we do not have a reagent. So that means that now the problem is not the doctor's issue, it's not the knowledge issue, but the reagent. So how are we going to get the more reagent for the next round? That will be the care you need to be uh, looking for, and that's a change you need to be addressed. Okay, so motivation, if increase if practice sees audit important. Okay, so when we have the result to inform our people, usually they have the result to see. No, every one of us have the result to see, then we know, oh, we are not doing good. So then we say, okay, we want to improve it, then we think, of a better solution. Okay, that is how audit help lah. Okay, so everyone together brainstorming to look at the new ways of working and whether we can implement it better lah. Okay, so sometimes doctor have knowledge, but they say they are too busy, they are unable to order. So whether we can let the nurses to check first whether patient have the test or not, and then to keep the reminder there to remind the doctors or how. Okay, so all these are we so-called some brainstorming solutions to see the team how to implement it. Okay, so it's good that we have a flow chart of our own clinic. This is just an example of our own clinic. This is a student, okay, a group of students, undergraduate students who who conduct the clinical audit learning process, which we ask them, okay, to try to have a flow chart. Who doing what during a patient who come and do, their clinical follow-up, so that they do the flow chart. Then they know when this thing is not achieve the target, who are the person involved, what is going on. Okay, then we can see from where we can intervene, we can get the recommendation. Okay, maybe if they are not doing the fasting dextrose every visit, then probably these triage counter people who in charge of it need to be targeted and to see how can make them remind them to do every visit, things like that. Okay, so that is just an example lah, for everyone to see it clearly. Okay, have we succeeded improving the care? So we already look at what have happening, and then we have suggest some solutions. Now everybody have to go back and work on it, to implement it, to use the solution suggested. Okay, so but then later we want to see whether it have better improvement. Okay, this is why later, maybe 6 months or a year later, we need to repeating the cycle. Okay, we will repeat the same cycle, which of course the topic already the same, and all the criteria also the same, and we use the same method to collect the data, then showing the data again, and then again we'll see whether it's improvement or not lah. Okay, so that is how the clinical audit cycle works. All right, any questions? Anyone have any questions at this moment? All right, so if not, okay, is there any question? Let me see. Yeah, it seems that let me see. We have any question? All right. No, no question. Okay, it seems that no question. So that's we goes on. Okay, little bit about the difference between audit and research. Okay, in the audit, we are asking ourselves, are we following the best practice? Because the best practice is defined by either the protocol or the guideline you all agree in your clinic. Okay, so and you're looking for improvement against the known standard. Guideline already telling us patient with this, it need target for this. Patient with comorbidity, it need target of this. This is which acceptable standard which guide by the guideline. Okay, you never involve a completely new treatment or practice. Okay. Yeah, so results are specific and local because you are interested in your clinic only. So the result are interest in here in our clinic only, right? And then may lead to change in the practice. After it, you already discuss with your team and you see whatever is not good, you want to have changes in your practice. It's a cyclical process because we will going to repeat the cycle again. Whereas research is what is best practice. Okay, so because it's discovery for a new informations and new knowledge. So this is the different. Okay, understand? May involve a completely new treatment or practice. Yeah, so some people, they have some innovations, interventions, they test it and see whether it's effective or not. All right, so that is a new knowledge. Results are generalizable. You want to generalize to bigger population, not only to your one clinic. May need to lead development of a new services of practice. One is effective, you test it effective, then you publish your result, you go and tell the evidence out and say, oh, so to hope everyone can follow these new services. Okay, it's a linear process because you only do it once. Okay or not okay, finish. Not like the audit, no, we try to change it a bit, then we repeat again and see whether our solution is it work or not work. Okay. Okay. Yeah, so now just have because this is a workshop and to get you all know little bit of the what you have understand from it. So because it's online, though it's difficult, but last time we have do lah. So you try to choose a topic you intend to carry out in your clinic. Yeah, so it's diabetes care, hypertension care, which I mentioned. Maybe you look at other care. So would you like to carry out an audit on the process of the chosen? So what is the, try to write 2 or 3 indicator for the audit of process or outcome or the structure, but the process is the important one. Okay, determine the what is the inclusion and exclusion criteria for the audit project you want to carry out. So determine the indicator and the criteria. Okay, so the indicator and criteria for the process and indicator criteria for the outcome if you have. Okay, then determine the target of performance. Okay, I give you about 10 minutes or so. Then you post your results. Whether you want to say it out, you can, or you post some in the chat box so that we can discuss a little bit on this. All right. So now is okay, now is 3:50, right? 3:50, yeah. So maybe 4:05 4:05, we can try to, I will see if 4:05 we have some result you have post in your chat box, then we can start discuss lah. Okay, I leave you for a while to think about it, and then we will discuss. Okay. Yeah, so if you do not come out with anything, then I will not able to discuss lah. Yeah, but if you want to test whether you understand the concept or not, please post what you have think and put in the chat box. Okay. Yeah, yes, Naveen. You're muted, Naveen.
Yeah. So you give them how long? 5 minutes. 10 minutes.
No. I give them about 15 minutes. Now it's 3:50, right?
Yeah, 3:52.
Yeah. So we go 4:05 lah, 15 minutes
Okay.
for
Okay.
them to
So
think a little bit. Yeah.
okay. Sure. Can carry on. No problem.
Okay. Yeah. So now we have, let me see the chat. So there are a few questions in the chat. Okay, so yeah. So I will see, okay, first is the Aina, right? Okay, Aina have no Aina. Aina has said asthma patient who has done spirometry. All asthma patients should have done spirometry to confirm the diagnosis. Inclusion, okay, so you want to, okay, basically your inclusions are, you want to see whether patients should have done, this is your justification lah, who has, so all person should have done, okay, so inclusion, asthma patient who is above 12 years old, asthma patient who has regular follow-up, okay, so then you probably want to define sikit lah, regular follow-up tu is apa maksud regular follow up, okay? So ada datang lebih 3 kali ke macam mana? Okay? If not, then it would be regular to need to be defined. Exclusion, asthma patient below 12 years old. Elderly patient who is unable to do spirometry. Okay, that's quite appropriate. So indication, okay, so you justify little bit, you think why spirometry is important. It's a gold standard in diagnostic asthma. At least 50% of registered asthma patients do spirometry. Okay, that is what, so your indicator, so you try to give an indicator is spirometry lah, performing apa spirometry in diagnosis patients. Okay, that is a indicator. Okay, criteria to perform, have spirometry perform lah, right? Have spirometry perform bila? Yeah, I have to see spiro at least during at least this follow-up ke, or at the beginning of your diagnosis ke, or when? Aina, do you want to answer the questions? Are you here, Aina?
Like at least once in at least once lah in a visit.
Within the visit mean within dia punya follow-up visit. Semualah dari depan ke belakang lah maksudnya.
Yes, because I noticed there's not so many patient who has done spirometry yet.
Yeah, tapi you punya klinik ada spirometry, is
Yes,
it?
ada.
Okay. So at least you have one spirometry reading during the
Follow-up.
during the follow-up period lah. So you punya spirometry ni, how frequent usually you buat spirometry tu?
I think it's not that frequent because
You all buat for diagnosis, mean in the clinic, you buat for diagnosis sahaja ke atau you buat for follow-up pun you buat?
but usually for new diagnosis, the new patient.
Okay, so you have to write, as at least spirometry, at least have one spirometry documentation, okay, during the whole clinic follow up lah, means that you bukan for this year ke apa, you from dulu sampai sekarang kan.
Yeah.
You rasa ada satu tu then you can confirm the diagnosis lah. Okay, I think that is quite fair. So this is audit on the process juga, yeah, audit on the process juga. Okay, so okay, at least you, okay, that is can, okay. Boleh, okay, topic audit of Naziro, audit of intermittent asthma patient juga, okay, more than 80 years in the clinic, So ini, okay, let me see, baca lagi. In the clinic, comparing the proportion using both controller and ICS, both controller and ICS, now versus previous practice of controller only. Okay, process audit prescribing pattern, process audit prescribing pattern, eligibility criteria, inclusion age, more than 18, diagnosed with intermittent asthma on treatment attending your clinic, exclusion kurang daripada 8, persistent severe asthma, incomplete records, other similar respiratory. So persistent severe you mau exclude, okay, indicator and criteria, number of eligible patients on controller plus ICS. Controller itu ICS lah. Siapa ni ya? Let me see. Naziro. Dia
Oh, sorry,
control.
Doctor. Reliever. Sorry, typo.
Reliever
Reliever.
reliever tu. Okay. Age persistently severe. So mengapa you mau exclude the severe asthma ni?
Just to see the intermittent one, whether they have changed to the newer latest guideline using both ICS and the controller, Prof.
The reliever. Tapi
Yes.
biasanya dia guna, you maksudnya you mau tengok dia combination terapi, dia nak guna yang macam combination punya medication atau dia separate punya medication ke?
Combination. So for intermittent use, the latest guideline they were mentioning we have to use both ICS and controller, right, Prof? So now because the
Reliever and
later
controller lah, means
ah,
that
ah, ah,
itu intermittent means that orang yang dia belum on the maintenance
ICS
punya terapi punya patient lah.
correct.
Okay. So okay, I try to get what you mean. All right. So means that okay. So usually when you do the audit kan, dia biasanya you mau pukul sekali untuk semua lah, faham tak? But of course,
Alright.
this is an exercise. So you will audit on asthma care. Let's say audit on asthma care. Whatever related, even tadi macam siapa Tadi Aina kan? Okay, Aina dia try to give one example. Padahal when you audit on asthma care, semua yang you rasa appropriate tu you letak lah. Mungkin spirometry done tu for every ini satu indicator. Then the second indicator is prescribing prescribing in controller and reliever for intermittent asthma patient. Macam tu lah. Okay.
Understood.
So then that is the process. Then you will see yes or no lah. Okay. So kita biasanya dalam audit ni kita cover more wide lah. Of course, this is an exercise. That's why you look at specific saja. Kalau research, dia look at very specific punya satu target population. Macam ni, dia macam ada sikit research punya komponen lah. Sikit. But one of the indicator, kalau dia jadi audit, dia maybe is one of the indicator of asthma care. Okay?
Understood.
Tapi kalau dia jadi research, dia akan jadi satu ni ajalah. Faham tak?
Faham.
That's why mengapa I tunjuk you the research and the audit lah. Okay, so yeah, but I understand what you mean lah. So means that it should be, I mean like for this exercise is fine lah, but if for the real audit, because we are audit on our care kan, so that's why kita nak semua orang kita nak apa related to this care punya benda kita capture at one go lah. Kita tak mau satu kali kita pergi buat check spirometry, satu kali kita pergi check intermittent sajalah. Then we waste a lot of your time. Okay?
Alright, thank you, Prof.
Yeah, understand what you say. Okay, but okay, so it's quite appropriate, I can say, but it's a total number of eligible intermittent asthma patients. So when you look at this indicator specifically, yes, you punya indicator is this group of patient lah. And then lepas tu berapa orang ni dia prescribe tu betul lah. Okay? Right. Can? Yeah, that's quite betul. Okay, so ada yang tanya, smoker. So default, but ni apa, exclusion, smoker exclusion, defaulter or lost follow up. Yes, wah, pernah ada yang tanya kan. So patient you have to have it will depends on how do you define whether you are the appropriate kan, appropriate time for you to give this management lah. Kalau you rasa the first go you nampak patient macam tu, you dah terus kena tu, so you tak ada period sangat lah. Mungkin you only for the last 1 year punya patient who attend the clinic. So you ada satu frame of timeline lah. Tapi defaulter tak defaulter mungkinnya tak jadi sangat isu for your indicator, because kalau dia default pun sepatutnya nampak dia hari tu dengan you pasti dia guna intermittent like that, you punya prescription should be correct lah.
Yeah.
Betul. So dia tak ada kaitan sangat dengan yang itu. Okay. So this one, documentation of smoking status to check. If smoking status is recorded, okay, in all above, okay, ini dia mau tengok. Stoza inclusion, all patient 18-year-old above have visited to clinic during the adult period, exclude less than 18-year-old. Okay, decrease during the audit period, indicator percentage of eligible patients. So indicator is smoking status lah. Okay, the criteria will be documentation of smoking status in the medical record lah, at least once kan, at least one during the follow up lah. So mungkin percentage of current smoker who have documented. Okay, so yes, okay, I understand what you say. Okay, quite correct. So it's just example. Okay, the next one is audit on M-chart screening among, so you get one indicator correct lah, I can say. Okay, so audit on M-chart screening among patient aged 18 to 24 months in clinic kesihatan. Right, process audit to look whether M-chart is being used consistently and appropriately for eligible children. Inclusion age 18 months to 2 years. Okay, exclusion other than stage age outside from PK June. Okay, so you nak tengok you punya performance di tempat tu aja already confirmed diagnosis as autism, so you tak payah screen lagi. Okay, indicator will be the M-chart screening lah sebenarnya kan. Criteria you want to see whether M-chart usage imbukakan screening done or not lah. Activity correct and interpretation. Okay, so you kena bagi period lah for your criteria. You kena, because they can start 18 to 24 months kan. So mungkin you nak ambil budak yang 24 months lah. Okay, kerana you jangan, because kalau you ambil 18 months, you faham tak? 18 months, you masih boleh, you tak buat. Kalau you ambil 18 months tak buat, 19 months tak buat, is it you tak buat? Is you tak buat adequately? Tak semestinya kan? Because you akan bagi timeline sampai 24 months. That's why I understand lah. Your guidelines say you buat between 18 months to 24 months. So kalau you mau tahu budak, you mau tahu you punya staff buat tak buat betul tu, you kena ambil semua budak yang 24 months or above lah. Kerana macam itu baru you boleh tahu mereka buat ke tak buat. Boleh tak, Ruzana? What do you think?
Faham Doktor, faham. Maksudnya atas, so that we can retrospective see lah betul-betul tak?
Betul, because macam tu baru you boleh tahu dia buat tak buat, faham tak? Kalau dia 18 month dia tak buat, you tak boleh salahkan dia, bukan you tak betul kerana you bagi timeline sampai 24 months tu. So you kena bagi dia punya period yang dia boleh sampai 24 months tu lah, baru you audit, then baru you fair lah to yourself and to your staff. Macam tu.
Okay Doktor, thank you Doktor.
Okay, right. Okay, topic, how many women in the reproductive age group? How many women in the reproductive age group with type 2 diabetes has been enrolled into the PPC clinic? Okay, women between age of 30 to 45 years old with type 2 diabetes. Okay, exclusion, women more than 45 years old with type 2 diabetes, target performance. Okay, so this one is tricky sikit lah. Okay, first you have to ask ourselves, what is the pre-PC ni kan? It's for people who want to plan for their pregnancy. Betul tak? Tiba.
Yes, correct, doctor.
Yes. So your inclusion, with title that has been enrolled kan. So bila dia enroll, dia tak semestinya ikut age group dia lah. Betul tak? Kalau dia younger and she's diabetes, let's say now she's 20 years old, she going to marry, and then she want to plan for her pregnancy, she should be include lah
Correct.
in
Yeah.
the PPC. So you cannot set 30 to 45. That is not fair lah. Okay. So it will be the eligible patients who want to go for. So when you want to this one, okay, so you have to see lah. When you manage a diabetes patients, how is it like? You know, first is should be they should ask the patient lah whether now they are sexually active or not lah. Betul tak? Kan? If they are sexually active and then it's possible to get pregnant, then it's good to enroll in the PPC lah. Kalau is not sexually active, dia single, katakan dia ni, takkanlah kita nak masuk dia dalam PPC.
Yes, doctor, correct.
Okay, so that is the inclusion as criteria which you have to consider. And then if you want to look at one process kan, is like whether you have assessed patients what to say the intention to for pregnant ke apa ke, you might want to have that questions in your process, you tanya lah. So once dia dapat the process tu, dia tanya tu, and then kalau patient jawab ya ke apa ke, then baru PPC, or dia sexually active and you rasa dia perlu pergi PPC, then you buat those lah. Alright? Okay? So, alright. So that is how we go about. Okay? Thank you everyone who have put up your questions to your answer to but okay, bear in mind that all of this is a very short punya exercise. That's why you come up with one indicator sahaja lah. Alright, so and I've discussed brief on that. So for audit, clinical audit, I emphasize again, usually when you do a clinical audit, you won't do on one indicator. All right. So that's why it should have, the topic should be, that's why we say the topic is not one indicator. Topic is what is diabetic care, PPC care, asthma care. Okay. Under PPC care, what is the thing you need to implement? Important thing. So you pergi balik ke guideline, you tengok balik apa yang sepatutnya you perlu buat, and then to buat to the patient, and then you think people, then you buat and see sama ada betul-betul you buat ke tak buat ke. Same as asthma care kan. Asthma care tu ada banyak lah, macam ada spirometry, peak flow, buat ke every visit. Then apa lagi, education, ada bagi asthmatation plan ke, ada counsel on that ke, and then sampai prescription tu betul ke tak betul ke. That is all the process you might want to look into in this asthma care. So you can list the indicator first, then the criteria, then you can trace out what you want to look for that. Then only you go and carry out the this audit about this asthma care. Okay, so yeah, very good of you all have put up this so that we can discuss, and hopefully by the discussion you will be more okay, ada siapa lagi ya? Ada tiba-tiba ada keluar. How many women reproductive has enrolled? Okay, tak ada. Okay, Kemutu. Kemutu Kemutu have put up something. What is it? Kemutu?
Hi, Dr. Sita here. Yeah. I shared the hypertension audit that we usually do in my KK. So since doctor mentioned because we are running out of time, we only discuss on one indicator. This one is the example of all the indicators. There are for hypertension, what we look at, what is the target, and then what is the performance outcome that we usually check upon. So first we start with how many, from the patient, whether they are registered in the hypertension registry or not. Then the MO punya clasking, whether history there got mentioned on comorbidity, target organ damage, complications, the severe risk factor, namely smoking, like that, and then compliance to treatment. Then examination, the weight 1 year ago and then latest weight. Then BMI 1 year ago punya and latest one, waist circumference and then BP. And then the heart rate and then whether signs of heart failure is mentioned or not. In CP, the physical examination is the feeder edema and then bilateral cramp. And then annual investigation is the routine CVD blood screening, ECG at baseline, and chest X-ray is indicated. And then the risk certification is the global CV risk punya FRS scoring. And then management will be non-pharmaco and also pharmaco. But here we include together the lipid lowering drug because if let's say the FRS score is high, we're not just looking at the hypertension protein, but also need to focus on the standing therapy and whether patient is put out appropriately, like dietitian, like weight reduction, management, and then health promotion is the cancer screening, the influenza vaccine, and all that.
All right. Okay. So, let me look into it a little bit. As you say, yeah. So, annual investigation 1 year ago and the latest lah. Okay, you want to see whether they have done, or this is they want the result or whether they. Of course, only they done, then only you have the result. So the process come first. Then after that will be the outcome lah, kan? If you have the result, then you can see the outcome lah, right? So fasting blood sugar, so when you have this renal profile, urine albumin, ALT, ECG, all those, if you have both process or outcome you're looking at here.
I think outcome, doctor, because already got the result already.
Yeah, so you look at outcome. If you want to look at process, you'll see is that everyone have it lah. Okay, so if you confident that everyone have it, everyone have already like 90% of your clinic have done this, then it's fine. Then you don't need to go through the process. But usually we go the process and the outcome together lah. All right. So because how do you know? How do the result, when they have the result, they process, they already done. Okay, like ALT, you say if indicated, how do you know it's indicated or not indicated? You have to check back, right? So you have to check back. So how many have the process? For what condition one have order, then you know the process done or not done, how many of that lah. It's not just the results is matter to me because process also matter. If of course once you know the result is sangat kurang in here because it's an investigation, then you know the process is ramai orang tak buat lah. Yeah, but then you have to know that if indicated ni dia tricky sikit lah. So good to go process. What do you mean by indicated? Kan? Then only you can audit the indicated one. Dia buat tak buat macam tu lah. Okay. At baseline. So ECG at baseline tu, of course, we assume semua orang perlulah ECG kan. If we think that we have no problem in the ECG, memang you pernah buat the audit ECG memang hampir 90% semua patient buat, then you don't need to buat the process lah. Tapi if not, then you need to have the process. But again, you look at as I say, you look at the result. So if the result is there, that means that the process has been done lah. Okay. And if indicated ini, itu yang tricky lah. When you write if indicated, it's not clear. So if you want to be, if as we say kan, all the indicator and criteria have to be explicit lah. Dia betul-betul kita faham apa maksud indicator tu, so that one you can tambah baik lah the indicated ini. So then when you go to look at the data, then you know exactly what you are looking for. Bukan nanti A fikir lain, B fikir lain macam tu. Alright? So CVD risk stratification, I suppose CVD risk question is also process and Nila, if you've done the risk stratification, then only you will know how many in high risk, low risk, or moderate risk kind. Okay, so optimizing management, also same thing kan, you must have a non-pharmacological yes or no, whether you advise or not advise, there are process, there are audit on the process. Okay, and antihypertensive, bagi tak bagi also is the process. Alright, lipid lowering drugs if indicated. So this I can say the non-pharmacological, pharmacological and pharmacological lipid lowering drugs, these are all the process lah. All the process, because you bagi ke tak bagi, that is a process. Okay, mental hypertension's complications if indicated also is a process. Buat tak buat kan, you manage that maksudnya. So but this is quite broad lah, what exactly you mean. You think they would not manage the complications? How this come how do you think when you look at this mental hypertension complication, what you looking for when you go to the card? So if
Like
you
whether heart failure, sorry doctor, heart
yes,
failure managed or not, the complications of hypertension like stroke, some patient got stroke, got MI, whether appropriately managed, appropriately referred out, or the medication, ACE, ARB is on board, sub blocker, like that.
yeah, it's very broad lah. As you say, it's very broad. So you have to, so when it broad, so you have to have a subheading lah, the ABCD which you are looking for lah. Then each one of it, then yes, no, yes, no, yes, no. Yeah. So even if only like this, then it's not clear enough lah when you want to present at the time. So you say indicated yes. Let's say like you tell me 5 out of 10, right? So you say 10 people got complication, 5 be managed, another 5 not managed. Then you're asking what type of complication, those kind of thing. So it's good to have it. I mean to specify it lah. Okay, appropriate referral if indicated, health promotion if indicated. So referral of course maybe is when they have a complication or whatever, right? Then you say health promotion if indicated. No, is anything health promotion not indicated? I thought health promotion also indicated for everyone. What type of health promotion you means here? You are looking for here? So it might need little bit more clarity lah. Okay, it can be done. It's quite good, but then you have to little bit more clarity. Okay, so yeah, so that is the outcome. As you say, how many patients achieve less than 140/90, but then as you means if you have patient have comorbidities, okay, like patient who have renal failure with proteinuria more than 1 gram, or stroke patients, is the same target level. If you want to more detailed one, then you can put more, more detail. So if without that, those is this, and with that, then how many, let's say how many CKD patient you have with proteinuria more than 1 gram, you want them to be lower blood pressure, how many of them had that, okay? 5% weight reductions. So it probably you have say lah, the 5%, the baseline and the current or things like that. Then you can compare. Then you can do, okay, treated to target. Yeah, as you say, yeah, this will be the outcome lah. Yeah, tadi is the process kan. Yeah, so this is the outcome lah. Okay, so hypertension, yes, it's quite straightforward. We have the guideline and also, yeah, so you all have done, that's quite good. Yeah, just some clarification when you want to collect the data at the time. Yeah, so then you can tell yourself how is it. Okay, very good. Thank you. So this looks quite comprehensive lah. As you say, the diabetes when it comes to this you have done, of course, is more what to say more comprehensive. Okay, little bit more. Okay, I just look at the last one. Mammogram screening, like mammogram, pap smear. Oh, okay, that is you say about the health promotion, is it? Health promotion, is it? Nila? Yeah, okay. So that is probably another it's like not really is a hypertension care lah. It's another topic. So it might be carried out is another clinical audit. Those are you combine with the hypertension patient. Okay, if you want to be more focused. Okay, that is very good. Thank you, everyone. Okay, now I think I hope, yeah, with the discussion you all can understand more. I guess some of you already carrying out it. That's good. All right, so we go to the last bit. Okay, so last bit, I just want to show you some example lah. Okay, this is audit of hypertension in general practice, okay, which has been published many years ago in 2005, okay, in a medical journal Malaysia, MJM. Okay, so they have, I mean, I just want to show that they have actually write a very good kind of example of the indicators and criteria and the target or standard kind lah. Okay. Another example is a clinical audit of the diagnosis and management of chronic kidney disease in a primary care clinic by the UITM clinic. So this one have been published more recently in 2021 in the Malaysian Malaysia Family Physician Journals lah. Okay, so if you're interested, also you can Google this. I mean, you can access to it. So this is how they put the indicator criteria kind. Okay, and they calculated and they see achieve or not achieve lah. All right. So that's all. Okay, that's all from me. Right. So any questions you want to ask or clarify? Yeah.
No, doctor, thank you so much.
Okay, Kumota. All right.
Tiba, any question? Anyone, any questions? I know all of you are a bit tired, as well as the speaker and me also. But any questions you want? Maybe one final questions. So you all can do audit and can publish, right, in the Malaysian
Some of
Family
them
Physician.
have done with the clinic and the siapa Kumutu with the clinic lah. They have done the hypertension one, which they show. Yeah.
Okay, so you got limited budget or problem getting grants, you can do an audit, and you may get to publish in selected journals, okay. So so you get a publication, before you graduate from our program, okay. That's a big plus for you, in your career. Okay. If no questions or if you're thinking of the questions later, just use the link that I've provided just now to actually submit your questions. Once again, we'd like to thank Prof. Chiao for time. I think he's one of the experts in this audit in primary care. So if you do have any questions, please forward to the link that I've sent to you. And then we'd like to thank her, okay, for insightful, informative lecture. And okay, for the rest of you, okay, thank you very much. It's been a pleasure actually imparting to you all this so-called professionalism and ethics, okay, and this will help you in your next few years as a student and later on when you become a family physician, okay, consultant family physician, specialist family physician and future, okay. So thank you very much and best of luck to all.
Okay. Thank you, Naveen. Thank you, everyone.
Okay, thank
Bye.
you. Thank you,
Thank you,
everyone. Bye.
doctor.
Bye.